the presence of AV fistula in choosing the embolizing material. As we showed, you showed that we choose the embolizing material according to several factors. We ignore the presence of AV fistula. For example, I can't use PVA or histoacryl in case of presence of high flow fistula. So it's important to discuss this.
Okay. Yes.
You understand? Thank you.
Dr. Ahmed, thank you for your presentation.
Thank you.
Are these all post-nephrostomy cases?
No. It's written in wrong. It was a mistake by my colleague. Yeah, most of them are BCN, percutaneous nephrolithotomy. No, not nephrostomy.
So it's not.
Yeah, no, that's.
And were the nephrostomy cases done by urologists or interventional?
Urologist. No, urologist.
Urologist.
Yeah, we do difficult cases of nephrostomy, but most cases because they are in the emergency room all the time, so they do simple cases of nephrostomy while we do difficult cases.
So, and you mentioned two non-pushable coils. So what do you mean by non-pushable coils?
Mechanical, because we need
detachable coils. You mean
detachable? Yeah, detachable. Yeah.
Thanks. Professor Tarek.
Yeah. Thank you, Ahmed.
Thank you.
Nice. Good work. I have a technical question. Did you use microcaster in all cases?
No. In selected cases because it's very costly and just the case here I mentioned here we use it because it's very costly to do microcatheter and most of cases are large aneurysm. So
yeah, sure. It depends about the how you can super selective casterize the injured vessel. If you can do it by the standard caster, it's okay. It will be cost effective. If not, you can resort to the micro.
Yeah, that's what we did.
Yeah. Thank you, sir.
Thank you.
Going back to cost effectiveness, Dr. Ahmed, did you try using glue for any of these cases?
No, in my experience, no. I didn't use glue anyway.
Okay. Dr. KERIM.
Thanks for the talk.
Thank you.
When you have such a pseudoaneurysm, it has no real lumen. So I wanted to ask, when you coil it, do you coil the aneurysm or do you coil
No.
I
coiled the feeder vessel.
Just a feeder
before
vessel.
Before I reach aneurysm. Yeah.
Did it ever happen that the coils prolapsed?
No. Because I upsized the size of the coil to the parent vessel, so it doesn't go up.
Any other questions? Thank you, Dr. Ahmed.
Thank you.
It's my pleasure to introduce now my dear friend and colleague, Professor Dr. Amr ABDEL from Alexandria University, talking about the efficacy of needle tract occlusion to prevent pneumothorax after CT-guided lung biopsy. Professor Amr.
Well, thank you, Dr. Hassan to Mustafa. Needle tract occlusion to prevent pneumothorax after CT-guided lung biopsy. Lung cancers carries the highest mortality among all cancers. Fortunately, the new target therapies had improved the prognosis. But to offer these therapies correctly, we need to have an optimum biopsy, able to get all the ancillary pathological studies. Optimum biopsy, it means an efficient biopsy with good quality tissues, but at the same time, it should remain safe. Bronchoscopists offer the safest biopsy, however, they are not always efficient. Whereas surgeons, they get very efficient biopsies, still they are not always safe. Needle biopsy offers a simple, easy, fast, and cheap way to get biopsies. We are safer than surgery, and still you are more efficient than the bronchoscopist. However, whenever we transgress an aerated lung with a needle, we are simply inviting complications, and at the top of this list comes the pneumothorax. This could be asymptomatic in most of the cases. However, when it worsens, the condition might need the insertion of a tube. This will result in a higher cost and hospital admission. Definitely neither the patient nor his relatives will be happy for that. In a large available meta-analysis to date encompassing around 23,000 patients, the rate of post-biopsy pneumothorax was about 26%, and in 7% chest drain insertion was needed. The potential causes are variable with long lists of published causes across the literature between significant or non-significant factors. Still, the commonest causes are biopsy of small lesions less than 2 centimeters, biopsy of deep lesions at 2 centimeters on the surface, or whenever we biopsy through an emphysematous lung or when we cross bully. So to limit this risk, various technical modifications had been published in the literature, either to put the patient down after a completion of the biopsy, or to put the biopsy site from the beginning at the more dependent lung, or simply to seal the tract. Sealing this tract either with a droplet of saline, autologous blood clots, or with gel foam slurry. So we aim to show our experience in Alexandria University to seal the needle tract with a gel foam just to avoid the post-biopsy problematic pneumothorax. And we have been implementing this technique since 2016. We prepare the gel foam in the normal regular way as we do with all of our embolizations. Biopsies are performed in the coaxial regular techniques, and upon a completion of the biopsy and upon withdrawal of the cheese, we start to inject small aliquots of gel foam droplets along the tract to occlude the tract, resulting in this small cast. So during the study period, 132 patients, 70 with non-sealed tract and 62 with sealed tract. We got pneumothorax in around 13%, chest drain was inserted in 4%, and with the sealed tract group, the rate of pneumothorax fell to 4% or 5%, and chest drain was not necessary. An example of a large lesion, peripheral with emphysematous lung. After biopsy, pneumothorax, few minutes, again, tension pneumothorax, just few minutes, tension pneumothorax, and chest drain was inserted. A case with the same similar lesion, emphysematous lung, biopsy, core biopsy, sealed tract, no pneumothorax. A second one, similar lesion, emphysematous lung, biopsy, sealed tract, minimal pneumothorax. Fortunately, no chest drain was needed. A third one was a deep lesion, biopsy, core needle biopsy, sealed tract, nothing, no pneumothorax, no chest drain. A fourth one was a deep small lesions, core biopsy, sealed, same result, no pneumothorax. And the fifth one was even smaller lesion, core biopsy, tract sealed, no pneumothorax. Is this procedure risky? So I've encountered a gel foam leakage in a vein in only one patient, 1.6%. This was a patient. After the injection, we noticed the intravasation into a vein, however, with no clinical consequences. We have not experienced any endobronchial leakage, I think because we are just injecting very small amount of gel foam. Briefly, problematic pneumothorax is a nightmare for any radiologist doing a lung biopsy. Sealing the tract with few droplets of gel foam slurry can improve the safety of the procedure. Thank you.
Thank you, Dr. Amr. But I have a question. Did you try glue in occluding the tract or no? Did you try glue?
Gluing the tract?
Yeah.
I have no need to glue the tract. Just a few droplets of gel foam was enough. And just inserting glue is to acryl. Why should I take this risk?
I think it may be more effective than gel foam.
No, gel foam was very enough. Sometimes we see it with saline. Same result.
Okay, thank you. Any other questions?
Thanks for the nice talk. We know that the gel foam, when it's applied into arteries, it will dissolve after 48 hours.
Yeah.
Do you know whether this dissolves, or do you have like follow-up imaging where it's gone, or does it stay?
Actually, I've done a follow-up for a few patients. The gel foam inside the tract had completely disappeared. Okay.
And do they have any form of pneumonia there? Or
no, at all.
محمد، أنا اسمي دكتور حسين عطية، ازي حضرتك؟ المهم أنا سؤالي هو نوديول زي اللي أنا شفتها في السي تي دي اللي هي 1 سنتيمتر
Yes.
دلوقتي ترو كات بايوبسي سواء إذا كانت أوتوماتيكلي فولي أوتوماتيك أو سيمي أوتوماتيك النيدلز في نوعين نيدلز، نيدل بتخش 2 سم و2 3 مللي،
Yes.
في نيدلز تقدر تعملها تكتين زي ما بيقولوا، تكه واحده
سنتي و2
1
سنتي.
سنتيمتر.
Yes.
The problem with that is دلوقتي if هي 1 سم، انت عشان تاخد a good biopsy a good core without repeating it لازم to puncture the nodule وتبقى fixed فيها رغم ان هو بيتنفس. لان لو جيت من السيرفس من بره وخبطت اجزاء definitely هيحصل نوموثوركس، او انك استعملت اتروكا ان هي بتخش 2 سم ونص more than the lesion itself، هتروح تاخد من healthy sound وتعمل نوموثوركس again. فازاي to avoid ان احنا نخش وفيكس the needle او the tip of the needle which is very difficult in a case like the last two اللي شفتهم without ان انا to push او to displace a nodule في البروسيدور. How could we avoid this?
اخر حاله اللي عملناها yes the last one actually هي دي the smallest one. The last one we punctured the nodule with the trocar. We inserted the needle and we opened for the 1 centimeter, just 1 centimeter, not to bypass. Actually I bypassed the needle with the puncture point of the needle, but the cutting portion was completely inside, and the remaining of the cutting portion was inside the trocar. So I've just cut the small part of the nodules while the remaining part was fixed, anchored with the cheese. Yes. 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 Yes.
Okay. Thank you very much.
Thank you, Dr. Amr. Thank you to you all. Now we are at the end of our session. Thank you.
genorenal shunt. This is for them. Then we go to the shunt.